Um, I'm back for those just joining us. This is the other usual component of our CON hearings. This CON application concerns so this CON application was filed by Encompass Health Rehabilitation Hospital at Branford, docket number 25-32826-CON. We had some of the technical portion earlier today, so we're going to turn our attention now to public comment. We started public comment sign up at 9:30 this morning, and it has continued until now. If you haven't signed up and you wish to provide public comment, please state your name in the Q&A section. The order of the comment will start with Representative Robin Comey. We normally start with elected and appointment officials first, and then we'll move on to the clinical professionals and other executives, and then anyone else who also has signed up. We typically limit our public comment to 3 minutes, with public officials being granted a little leeway. So with that, Representative Comey, you're free to begin whenever you're ready.
Okay, I just want to double check that you guys can see me and hear me, because it's very stuttery on this end.
We can see and hear you.
Okay, very good. Then I'm just going to carry on like that's not happening on my end. Hi, good afternoon, everybody. Thank you so much for accommodating my schedule. I very much appreciate it. My name is Representative Robin Comey, and I proudly represent the residents of the 102nd District, which is a good portion of Branford. I am here today to happily offer my support of Encompass Health's application to build a 50-bed comprehensive inpatient rehabilitation hospital proposed on Route 1 on the eastern end of Branford. Right now, high-quality rehabilitation care doesn't exist in close proximity to my community, though we have a wide access to other kinds of care. So I am grateful to Encompass for leading this business and healthcare opportunity in Branford. In fact, just the other day, I was at the gym and overheard a family member sharing the trouble she was having with the logistics of having her loved one who is recovering in this type of care facility so far from her work and her home. So I do feel there is a gap in the region, and I also think that because of the demographics of the region, people who live here, I do see the opportunities for care growing. Data shows, and I certainly know firsthand, that patients heal better when family can be present. I was reflecting recently, just this morning actually, on being the primary and only caregiver for my mother when my children were young, and how important it was for me to be with her as her medical proxy and, most important, family advocate. I know that she recovered faster when I was there, and that the medical staff were filled in by myself on a regular basis about what her baseline health looked like, as well as her medical history that often, in her case, went well beyond the chart. My constituents and their family members will no doubt benefit from receiving care in the Encompass facility, should it be approved, for all those reasons. Additionally, beyond the clinical case, this project is an extraordinary investment in our community. They are promising approximately $70 million in local economic investment, 140 to 150 good paying jobs for our neighbors, including professionals and support personnel. Of course, we're welcoming a tax-paying business, which contributes to our local tax base. And as another note, I serve on the Regional Health Department's CHIP board, and I'm excited about having a new community partner at the table to work with us to improve outcomes for residents in the area. And I finally just want to note that as this project came up and I was introduced by it, introduced to it rather, I saw a family member of mine was celebrating being awarded Physical Therapist of the Year. And that was for Rhode Island. And I realized that he worked for Encompass Health Rehab Hospital of Johnston. So I reached out to my cousin and I asked him about his work with Encompass, and he spoke really super positively about it. And I think in those times, we really can't, in these times, we really can't underestimate the importance of providing quality care for not only their patients, but for their employees. So in conclusion, I urge this office to approve the project, and to the members that are here in the room, Office of Health Strategy, I want to thank you for your time and your commitment to expanding access to quality care across Connecticut. Thank you.
Thank you, Representative Comey. Next on the list will be Rachel Rusconi, a member of the Shoreline Chamber of Commerce.
Hi, everyone. Can you hear me?
Yes.
Amazing. So my name is Rachel Rusconi. I'm the president of the Shoreline Chamber of Commerce. The Shoreline Chamber of Commerce covers Branford, Guilford, and North Branford, and particularly where Encompass Health is being proposed. It is very central to those three communities. But I'm here today to talk about how this would be a positive addition to Branford and our shoreline communities. Right now, there is no comparable inpatient rehabilitation facility along the shoreline. I believe the next closest option is about 25 to 30 minutes north, which may not sound far, but for patients recovering from serious illness, surgery, or injury, for their families traveling back and forth, that distance really does matter. And it's especially inconvenient for those who live and work along I-95. So having the access to a facility on that corridor, I think is critical. Having Encompass Health here in Branford really does fill that gap in care. It allows residents to recover closer to home, surrounded by their support systems, which we all know leads to better outcomes. From a chamber perspective, it also strengthens our broader healthcare network. We have many members that are at-home care agencies and skilled nursing facilities that creates a more seamless continuum of care. Patients can transition more easily between services if that rehabilitation center is right here in our community. And then, of course, beyond healthcare, there is that economic win, not only having a new taxpayer in town, but bringing quality jobs to Branford. I believe they're proposing 140 to 150 jobs from professional to clinical, administrative, and support roles. So that will help grow our local workforce and economy. So simply put, I think this is the right move for Branford, and we're excited for what's to come with Encompass Health. Thank you.
Thank you, Ms. Russell. Penny Rocha, did you want to call the doctor?
If I may, yes. Dr. Biner?
Okay, can you bring up Dr. Biner?
I think I'm up. Can you guys hear me okay?
Yes.
I apologize for my attire. I'm off in North Carolina on vacation, so no disrespect to the committee, but please forgive. I just wanted to make a comment about the need for this in the area. I'm an orthopedic spine surgeon with Connecticut Orthopedics, and we see a lot of cases where somebody really needs a intensive rehab facility that can do several hours of rehab per day in order to recover well from spinal surgery. They often come in very debilitated, and some of them can't walk very well. And the short-term rehab equivalents that I see, we actively steer patients away from, honestly, because the care isn't as good as an intensive rehab facility where they can really get with physical therapy and occupational therapy several hours per day and make progress. And that need even goes so far as for me to tell patients that they can't have surgery unless they can have full-time family at home when they get home to take care of them, because the short-term rehab options aren't great. So I think there is definitely a need from a clinician's point of view, and I think some competition in this space would be good for the state, in a sense that if patients have a choice, then they're going to actively. They do go research them and they go visit them. And I think the facilities care will improve overall. So that's all I wanted to say. Thank you.
Thank you, Doctor. I said that Dr. Velasco signed up.
Yes, good morning, everyone. My name is Brian Michalowsko, or I should say good afternoon, I'm sorry. My name is Dr. Brian Michalowsko, and I'm the medical director at Encompass Rehab Hospital in Johnston. It's great to hear from the representative about our physical therapist who was named PT of the year this year. We're very proud of that. I want to thank you for hosting this hearing today and allowing me to talk about my experience serving patients in acute rehab. I'd like to first start and share that although I practice in Rhode Island, my family has deep roots in Connecticut. My wife grew up in Ridgefield, Connecticut, and we spend a lot of time there, my children and everyone. And so we certainly spent a lot of time this past month with the ups and downs of the March Madness tournament. I know that was painful for a lot of people. But I'd like to share a personal story for this hearing involving my father-in-law. Actually, about 15 years ago, he was an avid cyclist and was involved in a fairly severe bicycle accident when he was hit by a car. He had a lot of orthopedic injuries and had quite a long hospital stay at Danbury Hospital. And then afterwards, actually had to go to a rehab facility in Westchester to recover, and which was quite a bit of strain for traveling back and forth with the family, and just the overall experience was not great from what he told me. Thankfully, he got home okay and is doing well today. But I do believe very strongly that if he had a facility like Encompass where he could have gone to get his acute rehabilitation, that he would have had a better outcome, would have been home sooner, and would have been a lot less travel for the family. Here in Johnston, we are similar, a few years ahead of where we hope Branford to be, in that we only opened in August of 2024. And so I've been able to see this journey from groundbreaking to today, where we are most of our beds are filled and we're serving a really good job for our patients in Rhode Island. Some of the outcomes that we're really proud of this month, I know we keep track of our discharge to community, and right now this month, out of our discharges, 94% of those patients have gone back to the community successfully, with about a 3% rate to skilled nursing facilities and a very low, about 1.5% rate to be readmitted to our local hospitals. So I know that that's this month, but I can say that, and I see Matt Gooch in the audience who can certainly share that. For many months, our numbers back to the community have been well above 90%. So we've put a lot of capabilities in place. And one of my favorite stories I'll just share, because I do a lot of work speaking to our partner hospitals, and even though some of our partner hospitals have their own acute rehab facilities, we work with them very closely in the sense that we feel that there's a very large need for acute rehab, and that it's being underutilized. And so some examples I'll share with you. I was speaking to a second-year resident yesterday, and then there was also an oncologist I was speaking to at Mass General, and they were saying, we think this patient that you have should be, sent back to us for various reasons. And I shared with them, I said, well, we have the ability to do interventional radiology. We have an agreement with a partner. We have the ability to do dialysis. We have the ability to infuse a medication called a bisphosphonate. And they paused in the middle of the conversation and said, what kind of rehab is this? We'd never heard of such a thing where you have these capabilities. And we were really proud to be able to develop those capabilities so that our patients can get back to the community. They can avoid having to be readmitted to our local hospitals and then get the excellent care that they need. So I feel strongly that the Encompass method of working very closely in the community, having great capabilities and really striving to get patients back to the community is going to be an asset for the Branford area. So I'll leave it with that, and thank you again for this opportunity.
Doctor.
I believe Dr. Hasbani also joined. Dr. Hasbani, coming.
Doctor, are you there?
Mute.
I think you're on mute. there any other additions?
I believe Cindy Lee Gold is joining, but she may be joining at 2:30. So are you on? Hand raise. Yes. Oh, terrific.
Okay, so they were
Raising his hand too.
Dr. Gold was.
Lindy Lee Gold. Is a Dr. Gambardella? Yeah.
Yes.
Dr. Gambardella.
Hi, how are you?
Doctor.
Hi, thanks for letting me speak today, and I'll be brief. I think a lot of the key points were hit, especially with Dr. Biner. So I'm currently a podiatrist or foot and ankle surgeon up in the greater Hartford area. My office is in Bloomfield, and I actually live in Branford and hope to get a office branch down there within the next 12 months or so. So as someone who does surgery, I'm actually in between surgeries now. I can see how this unique facility would be very important to patients on the shoreline. These facilities require patients to have 3 hours of therapy per day, 5 days per week, and it really helps them rehabilitate quickly. I'm intimately involved in patients who have trauma surgery, especially lower extremity foot and ankle trauma, amputees, and a facility like this, which would be very unique to the area, would be beneficial for them. Patients are able to be closer to their families and their support system. And I just want to strongly urge all of you to really strongly consider this facility and the value it would bring to healthcare and patients in general. I am a huge proponent of this. I think it would be great for the shoreline. Again, there's nothing really similar to this that's close to the Branford area. And that's really it. I think Dr. Biner really hit the points that I would have hit as a, he's an orthopedic surgeon and we see kind of similar patients, although he's spine, but very valuable, very helpful for patients in terms of rehabilitation, and would be great value to the town of Branford and the shoreline in general.
Thank you, Doctor. Should we try Dr. Hasbani again?
Thank you.
Yes. Dr. Hasbani, can you hear us? You're on mute if you can hear us.
I think we're gonna have to move on. I apologize. If he's able to resolve the issue, so come back to him. No problem. You mentioned there was a Dr. Gold. I don't see.
It's Lindy Lee Gold, Senior Specialist, State of Connecticut Department of Economic and Community. But I don't see her on.
Yeah. We're gonna move on in the interest of trying to conclude the hearing today. For anyone attending remotely or in person, if you want to submit a written comment, feel free to do so. The email address is con@ct.gov. So we're going to pick up where we left off with direct by Frank Rosas. Going forward, I did want to mention there were some objections earlier that like didn't properly resolve, and I think that's because we were trying. But going forward, to the extent that there are objections, we should figure out how to deal with those, and then I'm not blaming anyone. Make an observation.
My understanding from your order is the interveners don't have the right to object.
Correct.
First, Mr. Gooch, just very quickly and primarily for the record, Mr. Gooch, do you recall that Ms. Letty examined you on questions 8, 9, and 10 of the completeness questions from OHS?
I do.
And I'll represent to you that those responses were submitted on October 26th of 2025. I'll also represent to you that OHS issued follow-up questions and Encompass responded on October 26, 2025. For purposes of the record, in issues question number 3, OHS asked for the underlying Encompass Branford selection of the Northeast region and exclusion of other regions when responding to questions 8, 9, and 10. Encompass responded that it selected the Northeast region because it made the most sense and to provide for efficient operation and oversight of the 173 hospitals in 39 states and Puerto Rico, and thought that the most reasonable way to answer was to provide information about the hospitals that operate in the Northeast region, given the location of proposed facility. In addition, Encompass provided that all of the hospitals are surveyed by state licensing agencies and accredited. From time to time, they receive survey reports with citations that necessitate the submission of a plan of correction. Encompass hospitals, upon receipt, promptly submit a plan of correction. And all of Encompass hospitals are accredited and hold unrestricted hospital licenses. Let me just ask you, are all of Encompass hospitals in good standing with Medicare and Medicaid?
Yes, they are.
And are all of Encompass hospitals across the country, including the Northeast, fully accredited with the Joint Commission?
Yes, they are.
No further questions. I do have a few questions of Dr. Charbonneau. Dr. Charbonneau, Ms. Letty suggested that you only focused on a comparison of IRFs and SNFs, and you correctly said, no, that's not correct. Just for the record, in fact, slide 12 in the presentation is entitled IRFs and long-term care hospitals treat different patient populations. Yes. And this slide specifically references Gaylord Hospital and Hospital of Special Care, correct? Yes. And do you recall that Ms. Letty also suggested that Gaylord Hospital's percent of patients discharged to the community was 50%? Yes. And that's not correct, right? That's correct. And what is Gaylord Hospital's percent of patients discharged to the community? 9.8%. And how does that compare to the Encompass national average?
Encompass Health national average here is 70%. 70.3%.
Correct. And the 70.3% is based upon CMS data, correct?
Yeah, CMS fee for service only.
And if you look at all payer source data, what is the Encompass national average percent of patients discharged to go home?
Last year was about 84%.
I have one last question. Ms. Letty also stated that LTACs take patients early in the recovery process. Do you recall that?
Yes.
Let me ask you, as a doctor, and based upon your experience, what does that mean to you in terms of the medical condition of that patient?
So what I think is that she was alluding to is that if you have a patient, for example, that's on a ventilator, they're not yet ready to go into an IRF because they're not able to participate in that higher level of physical rehabilitation. So they could go earlier to an LTAC facility to get care related to those kinds of very complicated medical conditions. I will say that our systematically, what we do is work with acute care hospitals to make sure that we have good throughput for them so that we keep track of our average length of stay from the time that they refer to us to the time that we admit them. And throughout the country, it's about 3 to 4 days. So we have a very good system of evaluating patients who are referred to us and helping to move them through the pipeline so that they don't sit at an acute care hospital when they're appropriate for IRF level care.
One last question. Those medically complex patients that come to the attack earlier, would they be able to withstand the required 3 hours of intensive therapy a day for 5 days a week?
Obviously, if someone is on a ventilator and they're bed bound, they're not going to be able to participate in the kind of therapy that we provide at an IRF level. When those patients do become, as I said previously, appropriate for IRF level care, frequently we get referrals from LTACs to take those patients over to an inpatient rehab facility. So they've improved to the level that they can participate.
Thank you. I have no further questions of Dr. Charbonneau, and I have no questions of Ms. Chi.
Thank you. Looks like Dr. Hasbani. So we'll allow one additional public comment. And Doctor, if you can limit your comments to 3 minutes, that would be appreciated.
Okay, can you
Hopefully we
hear me now?
Yes, we
Can you hear
can.
me now? Okay, great.
Yes.
So, I've actually, I've done my residency at Yale and I've been in practice since 1977. And my son is in practice with me. We're both neurologists. Um, Over the years, I've had the many occasions to have to send patients to acute rehab, and many times it was difficult to actually do so because there has been limited number of beds in the area adjacent to Yale, adjacent to the uh, southern part of Connecticut. Um, Many times we have used Gaylord Hospital, which is a great rehab hospital. And I've had the unfortunate occasion of having had family members there. Unfortunate because because my father-in-law was sick, but the work that they did there was great. Um, um, uh, there is a very important place for an acute rehabilitation versus a sniff when you transfer somebody, even with a stroke, that requires, the question as to whether they have the ability to participate in 2 to 3 hours a day of rehab versus maybe 2 hours minus 10 minutes or something like that. There's a very big difference between an acute rehab and a sniff situation. Uh, Not only that, but there are specific indications that an acute rehabilitation program would be much better than transferring somebody to a sniff situation, which many times happens in Connecticut because we do not have enough acute beds for rehabilitation. There are many patients, for instance, that have Guillain-Barré syndrome, where an acute rehab place is much more adequate than a sniff situation because they have had a lot more experience with many patients that have similar situations. Dr. Biner was talking about somebody who had had spinal cord or spinal surgery and said that he had trouble, the person might have had trouble walking. And that many times has to do with the fact that they may have had injury to the spinal cord. And so now we need an acute rehab situation where somebody understands the neurological problem much better. And, as anything else, a specialist in the field can do a much better work than somebody who has seen an occasional patient like that. Um, um, those are really the important aspects of why an acute rehab hospital would be welcome in Southern Connecticut. I don't have anything else to add.
Glad you're able to clear up the IT issues.
I'm sorry?
And I'm glad you're able to clear up your IT issues.
Thank you.
All right, so I think the next thing on the list will be cross-exam by Attorney Cowherd. Are you ready to move forward with that?
I am.
Okay.
My first questions will be for Mr. Gooch. If you could have in front of you your pre-file testimony at 554 about the planning for the Branford project. And in addition to that, if you're counsel or you don't have it, at page 493, which is the answer to the completeness questions on the referral sources with Branford facility.
Give us a second to gather that.
Give us a moment.
I'm sorry, what you referenced, what page?
Page 554 for your testimony. Page 493 for the answer to completeness question.
One second. So 5, 5.
One moment, please.
Yes,
Okay.
I'm still not finding it. I apologize.
Yeah.
5, 5. Yes.
554 of his pre-file testimony and 493 of the completeness questions.
I have.
Just one moment. I apologize.
I'm not going to count this against the. Yes.
Okay, I did find, my apologies, page 554. So it starts with the Encompass Branford project.
Yeah.
Okay.
That's what we're saying. Okay, all right. So just some questions on your testimony this morning. You said across the Encompass network of 175 hospitals, many of your hospitals are joint ventures, correct?
We have a significant number, or a number that are joint ventures with local acute care.
Yes or no? Yeah, there are. And this isn't a joint venture, correct? This is not a joint venture.
It is not a joint venture.
All right, thanks. And in fact, you don't have a letter of support, last I checked, any licensed healthcare facility in the state of Connecticut. Isn't that correct? I was on the portal last week. Last night rather.
I don't believe a letter of support. We also don't have a letter of opposition.
Okay. But no letters of support, right? Okay. And then let's turn to the answer to completeness question 11, and those lists of 8 hospitals. You don't have a letter of support from any of those 8 hospitals, correct?
No, sir.
Okay. And now let's turn to you. In this morning's testimony, when the subject of Medicare Advantage came up, you referenced across our network, we have about a 30% conversion free off into our facility. And you said that that's really, or you said that's because we're scrupulous with respect to, is this the appropriate setting for that patient's care? Do you recall that?
I recall talking about how before we get to a point of submitting patient for authorization, we will self-select out patients that are either too high functioning or not appropriate for IRF care. To answer the specific questions about the percentage of patients that we submit for authorization that get it, year to date, we're over 56% of that just in the initial request to have those patients accepted into our hospitals, which is up from just over 50% prior year.
At this point, I think it would be helpful if, it would, for interveners' viewpoint, furnish assistance to this agency if I could show Mr. Gooch the fourth quarter earnings call transcript and the fourth quarter slides of Encompass that just were issued February 6, 2020. February 6, 2026. So they're quite recent, hearing officer. May I? And we have a copy for the agency.
Provided with.
As I said this morning, I think it's in the interest of justice. I did notify hearing officer, and I said at that point that I seek to introduce.
Rocha, have a response to that?
I'll defer to the hearing officer.
I'll let it in. I'm not sure what relevance it.
Oh, I think you'll find it relevant. Yeah, if you could just spell thank you. Thank you. You get the transcript in front of you.
Do you have another copy for me, please?
We'll share one.
Yeah.
Appreciate it.
When you have the earnings call transcript, would you turn to page 13?
Sure.
I'm going to read a little.
Okay.
If you don't mind. So these are questions from the investors and the shareholders of Encompass Health. And Mr. Chickering, who's an analyst for Deutsche Bank Securities, asks a follow-up. He asks, representatives, including your CEO, CFO, who spoke on that call. I think you talked about earlier, I think you said the referrals were up high single digit, but admissions were way down. Can you talk about generally what you see from Medicare Advantage on conversion rates and where that went this quarter? And then from a legal perspective, how much leeway does Medicare Advantage have to deny post-acute care? And I just want to read the response of two of your senior executives. First, there's Mr. Colthorpe, who is your CFO. Yeah, so I'll start and then maybe pass it over to Pat. So historically, our total MA conversion rates have run between 25 and 30%, and that's going to compare to Medicare fee-for-service, which is in the same population, subject to the same Medicare coverage requirements, which is run in the mid-60s. And so that's been a problem all along. Particular payer, who shall remain nameless for at least this quarter, has always been our lowest conversion rate, but they dropped by about 500 basis points in the quarter. This is again, a contravention of Medicare requirements. So we do have the ability to take this directly to CMS. Because the change was so material in Q4, our first order of business is going to be to try and work directly with the plan itself and say, is there something different? Is there something we can do better to try to do that in partnership? But we're not going to wait and see the effect of that before we get more aggressive with this and admit an appeal strategy that Pat outlined just a bit earlier. So there's a problem. There's not you may self-select, but when you go to convert Medicare Advantage beneficiaries, your senior officers are saying Medicare Advantage plans are not that receptive to giving you pre-authorizations. Isn't that right?
Object to the form of the question and relevancy on the.
Well,
May I make my objection, please, and relevancy to the CON criteria?
How is this relevant?
It's very relevant because Mr. Gooch said that in fact it was self-selection and that they are going to be adjusting to Medicare Advantage. He said he didn't see it as problematic that there was a downward trend in Connecticut as opposed to fee-for-service, and an upward trend in Medicare Advantage beneficiaries. That's why it's relevant.
Okay.
I don't have much more on this. So then,
Would you be allowed to answer?
well,
He hasn't answered your question. Do you want to withdraw your question?
that's fine.
You're withdrawing your question?
I'm withdrawing the
Well,
question.
then,
Answer.
I would like my witness to answer, please.
Yeah, so I can't speak to what Mr. Colthorpe or Mr. Torr said. I will simply go back to what our experience has been in the Northeast region. So talking about conversion from a referral standpoint and an authorization standpoint are two different things. When we get a referral for a patient who has a Medicare Advantage plan coming from an acute care hospital, our clinical liaisons have the ability to say, you know what? I don't even think this patient meets criteria because they're too high functioning or too low functioning and should be going to another level of care. So we don't go for authorization on 100% of patients. For the patients that we feel have an inpatient rehabilitative need that can benefit from 3 hours of therapy a day, 5 days a week, we will submit those after the physicians who are independent have signed off on them to the Medicare Advantage plans for authorization. So, you know, the statistics for Q1 for the Northeast region are what I said they were. We have seen we were at the 19.4% at the completion of Q1 for Medicare Advantage mix, which is 150 basis points above where we ran last year. So, you know, I think again that speaks to the credibility that we have in the eyes of these plans who see the value that we provide, and the proof, as Pat said before, is in the pudding. That it's a great opportunity for that patient population to get the care they deserve.
So, contrary to what your senior executives are saying, you're saying that you don't see Medicare Advantage pre-authorizations as a problem at all for you.
Objection, that was not,
Well,
objection for the record.
let's try this. Okay, I'll withdraw that. Let's go on to what Patrick Tour says here, Chief Operating Officer. To the same question about, you know, having a material impact on your fourth quarter earnings. What I would add is that Medicare Advantage is required to operate with the same coverage criteria as traditional fee-for-service Medicare. They're allowed to have a prior auth requirement, which they do, but they are supposed to adhere to that same coverage criteria. And what we see on a daily basis, and this is not new, is the failure to adhere to Medicare coverage criteria. So we have typically taken that in stride. It's been a frustration of our referral service sources. It's been a frustration for us, and most importantly, it's been a frustration for the seniors in this country that deserve level of care. So still talking to where the payers are. So we have decided that there's no teeth in Medicare requirement right now, and that they have to do. So we're in a position, and well, we're going to pilot this, and we're going to take these claims are in alignment with the Medicare coverage criteria through the administrative appeal process, through the ALJ, and potentially beyond. We're optimistic. We feel the facts are on our side here, and more importantly, we're really interested in making sure that seniors have access to care. Everybody wants access to care. But what's being talked about here is the difficulty that, and this is not new, according to your senior executives, in getting pre-authorizations for Medicare Advantage beneficiaries as opposed to Medicare fee-for-service beneficiaries. Isn't that correct?
And Medicare Advantage patients require authorization versus traditional fee-for-service patients. That is an accurate statement, yes.
Okay. And we're talking to difficulties that Encompass has had traditionally in getting those pre-authorizations. Is that correct?
How I would answer that question is it is just different. I would say, I mean, it's different than what we see for traditional Medicare fee-for-service, but it is a process that, again, I feel our numbers speak to the fact that we have successfully been able to show the value that we provided those patients across the Northeast region, of which this hospital will operate, that patients who meet rehab criteria will get access to the care they deserve at a pretty significant rate.
Let's then look at, we're going to talk numbers for a moment. Look at page 24 of the accompanying slides.
Okay.
Okay, across the company, I'm on the Medicare Advantage. So what we see is Medicare, traditional Medicare, 2025, 66.5% of your revenues of Encompass revenues globally, as compared to 65.6 in fourth quarter 2024. You see that?
Yes, sir.
And then you compare 24 to 25 full year, basically the same, right? 65%.
Yes.
Right? Okay, when we look though at Medicare Advantage, which you're developing these good relationships with, what I see across the company is in 2024, that made up 16.8% of your revenues. And that dropped in 2025 to 16.4%. Doesn't that what the data shows?
Nationally for the company, that is what the data shows. If I could answer that question, though, specific to the Northeast
I'm just
region.
asking nationally. And then when we look at the fourth quarter,
Attorney County, I would like him to answer.
well, I'm asking, that's fine. I just asked him what the figures show. Hearing officer, I'll let lead.
So I would just reference the same point in time, fiscal year 24 to fiscal year 25. Again, going back to just the Northeast region, of which there are 27 hospitals, with Danbury being one of those. Our Medicare Advantage mix for 2024 was 18.2%. Year to date, quarter one of 26, 19.4%. So that's a fairly significant lift. So again, these are national numbers, and Medicare Advantage penetration is different in every market. So, the prevalence in one state doesn't necessarily mean that it's going to be as prevalent in others. So I think that explains maybe some of the differences we're seeing in the Northeast versus other parts of the country.
Can I ask you how many hospitals you've added in the Northeast region in the last 2 years?
Last 2 years, so we opened Danbury, Connecticut last year, so that'd be 2025. The year before that, Johnston, Rhode Island, and then if you're going to ask, in 2026, it'll be 3 additional hospitals.
Okay. All right. How about in the last 5 years? How many in the Northeast region are new hospitals?
It's new to the Northeast region in the last 5 years, going back to 2021. Johnston, Rhode Island was our newest hospital since 2014, I believe. Give me 1 second. Those are coming on this line. Yeah, so apologies. Yeah, so we're opening 2 new hospitals in Pennsylvania this year and then 1 in Bangor, Maine. But going back to 2025, I believe 2 is the number when I look at the Northeast region in particular. Johnston, Rhode Island, Danbury.
Last 5 years. Last 5 years.
And just this region, yes, we've, again, though, that 6 to 8 addition that I mentioned before is across the national portfolio of hospitals.
But what the data still shows company-wide is that in the fourth quarter, 2024, 16.5% of your revenues was coming from Medicare Advantage plans. And now it shows that that's dropped to 15.7%, right?
That's what it shows across the company, yes.
Thanks. All right. Now, respect to Medicare Advantage in respect to, basically 17% of Medicare Advantage is right now at the Danbury facility. Is that right?
As of this morning, yeah, correct.
Okay.
It's a new program, though. Again, we just got enrolled with these plans about a month ago, so it's statistically hard to answer anything other than present day for their Medicare Advantage percentage.
And in terms of the non-facilities that have letters of support, that's basically coming from physicians, right? I have Mr. Lucchini, who's listed as a letter of support. Dr. Lucchini, excuse me, Michael Lucchini. right?
Objection, Reynolds.
You're with them?
Not personally, but our company is, and
Hold on.
What's the objection? Sorry.
Relevancy.
Well, it's letters of support. I asked earlier. No healthcare facilities. Now I'm trying to get to healthcare providers of any kind.
Have you seen any of the letters of support that have gone into the record?
They're on the board class exhibits.
So I'm going to stay in the objection as it was raised. Maybe you can point him to the letter.
The particular letter? He is asking for the,
If you're going to refer to a specific letter, I would just like him to be able to.
well, I have in exhibit J, additional letters of support by Encompass, Branford, and exhibit K, this docket. So they are in the docket.
Referring, so it's Dr. Lucchini is at towards the end of exhibit J. It's the last page.
Yes, I
Okay. Well, what's your question?
question to Mr. Gooch, is he aware that Dr. Lucchini is part of a 2-minute practice?
I was not aware of the specifics of the practice, just a letter of support.
Well, there's also another letter of support from Philip Lucchini, also the other physician in the practice. Are you aware that Dr. Michael Lucchini retired?
No, I'm not aware of that.
And then out of the other physicians that are listed here, you've got Dr. Michalowsko, but he's a medical director for Encompass.
He's an independent physician who is serves as a medical director over at Johnson, Rhode Island Hospital. Who just spoke a few months ago.
Compensated by Encompass for his medical services, right?
Fair market value administrative stipend, yes, to provide administrative oversight. Not a reflection. There's not any element of care or anything like that applied to that.
And then Dr. Williams, same thing, right? He's the medical director at Encompass Rehab of Braintree, right?
Yes, he is.
Now I'd like to draw your attention back to page number 493. And your statement in your testimony that you consult with potential community partners before entering the market.
Give me one moment to find that. No, I'm not seeing.
Back
What's the page number?
493.
Exhibit G, 493, encompasses response to the complaint letter.
Give me one moment to locate that, please.
Page with the acute hospitals.
Chapin.
Thanks. Okay. Okay. Yes, I do have it in front of me.
When you were consulting with the community partners before engaging in submitting the CON for the Branford facility, did you consult with Yale New Haven Hospital and State Medical Center, in particular, those two?
I personally did not, but I know, well, again, I did not personally talk to them, no.
Okay, thanks.
I was just appointed though to my role in September of last year, so I can't speak to what who others before me may or may not have spoken with.
Okay, that's understood. And were you aware at the time that this CON was submitted that you were going to testify that both Yale New Haven Hospital, who you have estimated at 38.3% of your referrals, and Mid-State Medical Center, which is another 8.3, so we're coming up on 50%. Were you aware that they're mandatory participants in the bundled payment team program?
I'm familiar with their participation. Like mentioned before, Teams is prevalent in 8 of the 10 states in which we operate in. So yes, I'm aware of that.
Team, the bundle payment program that gives one payment for care of what you mentioned are the hip femur fracture and the lower joint replacement. That's a global payment for the 30-day period from the time of the procedure to either a discharge or what have you, right?
For the Medicare fee-for-service patients in which Teams applies, yes, that is correct.
And right now, the team program only started in January 1 of 2026 by CMS, right?
That's correct.
And in the first year, there is no downside risk to hospitals who participate in that program, as Yale New Haven Health and Mid-State Medical Center are mandated to do. Are you of that understanding?
Yes, I am.
Okay. But then, like other bundle payments that CMS has tried, now there's going to be downside risk for the hospitals starting in year 2. Are you aware of that?
Yes.
Okay. And there's significant anxiety in the IRF, inpatient rehabilitation facility market, about the impact of this bundle payment program on your referrals that you're relying on almost 90%, very high amount of your fee-for-service patients. They're going to come from traditional Medicare, and that's a significant, by far the largest payer that you're projecting in this CON, right?
Well, let me answer the first part of the question. In terms of anxiety, I'm not anxious about it. Again, we've dealt with bundle payment models in the past with great success. You mentioned before, yes, this applies only to traditional Medicare fee for service, which, with the increase in Medicare Advantage, the patients kind of speaks to. We're seeing a nice upturn. So I'm not anxious about it. I think it's pure speculation on. The question is pure speculation about the impact it can have. What I'm speaking to, I spoke to this morning, was the impact it has had, which is we've seen no meaningful impact of Teams since its inception in January 1st in the markets. In fact, our Braintree, Massachusetts hospital has the 4th largest year-over-year growth quarter over quarter, and that is a market where Teams is very prevalent in. So to speculate what it might mean down the road is not necessarily applicable in my eyes to this conversation. We feel very confident that between Medicare Advantage and traditional Medicare, and the quality of care that we provide, that we've talked about it multiple times now, that our acute care partners will find the value in what we do, regardless of the bundled payment plans, which again, we've lived through various versions of that in prior years and it had no meaningful impact.
Thank you, Mr. Gooch, but we're in agreement the program just started. And right now, there's no downside risk for hospitals to control,
Asked and answered.
correct?
I have noted for the record.
I'm-
Asked and answered.
Yeah, it was asking.
Okay, asked and answered, that's fine now. Can you turn to page 4 of the earnings call document I gave you?
Okay.
Officer Tucker, just for the record, I may be regretting my reference to the chair. These documents were not presented to us pursuant to the rule.
These are authenticating, self-authenticating. If you want,
My order didn't mention anything about deadlines for submission of documents, and we typically do at least allow for late files. So that's why I'm allowing it into the record. I figured it would be better to have it entered and to discuss it openly rather than, actually have it submitted later on and all sorts of havoc. So you can.
in fact, that motion was denied. So let me just ask you about the statement at page 4 of the earnings call, where your CEO, Mark J. Tarr, for the entire system is talking. And if you can look at page 4, the 5th paragraph down.
Yeah.
Okay. So there, Mr. Tarr says, we are keenly aware of market anxiety regarding industry regulatory changes, specifically the extension of RCD. What's RCD?
Review choice demonstration.
Okay. And the initiation of the team model. So that's what it says there, right? You're reading that?
Oh, I am. When Mr. Tarr, and again, I'm not speaking for him.
Yes.
I'm getting, I should be able to answer the question if you're gonna.
All I'm asking you, is that what's written there?
Yes, I see that statement.
That's transcript from your CEO. So your CEO of the entire Encompass Health and its 175 hospitals across 39 states is aware of market anxiety in the IRF industry, but you're okay with it. You don't share any anxiety as to team.
Well, by market anxiety, Mr. Tarr is referring to the investment community, not the hospital. So from an operation standpoint, these calls are with investment communities. This is related to that anxiety comment is geared towards them. Has nothing to do with how we operate. I'm not concerned as an operator that Teams is going to have a sizable impact on us, which we have shown already 2026 that has had no meaningful impact to us from a volume standpoint.
Just observation. I don't think shareholders of concern are considered part of the IRF industry.
Well, this was a call with the investment community, so I disagree.
There wasn't a question.
That's why I object.
So when we talk about 2 mandatory participants that on table 1 in response to your projected volume by fiscal year are going to make up almost 50%. You're aware that in terms of Yale, New Haven Health, they have a 24-bed IRU in Milford, right? Are you aware of that? All right. And at Lawrence and Memorial, there's another 16 beds, IRU beds in that facility. Correct?
I believe so, yes.
Okay. And then there's Midstate, which is part of the Hartford health system. That hospital has at Hartford Hospital, rather, a 26-bed IRU. You're aware of that?
I believe so, yes.
Okay. And it also has 10 additional beds at St. Vincent's Medical Center. You aware of that? Okay. And are you also aware that as part of the agreed settlement issued by this agency for Hartford Healthcare to acquire the Eastern Connecticut Health Network in Manchester and Rockville, there's also contemplated another IRU coming online within the Hartford system?
Not aware of that, no.
All right.
Briefly, since I'm thinking more about what you said, since this did come in late, welcome to when you redirect on it as well. But you can do written response if you find that to be better.
If there's any need, we'll do it later.
Attorney Cowherd, I just wanted to draw your attention to the fact that there's about 10 or 15 minutes left of your allotted time. I just know that
Both witnesses, they went over. I'd just like some liberty to then, I have no questions for the doctor, but then to speak with, have cross-examination for Ms. Chafin. So
you can have a little bit, but
a little bit extra
Yeah.
time. Okay, all right. Let me see if I have any more questions for. Yeah, I do have a couple questions on, for Mr. Gooch. Well, I'll make these quick. So if you turn to the earnings slides in 10.
I'm sorry, you said page 10?
Page 10. So for 2025, in adjusted earnings before interest, taxes, depreciation, amortization, in that year, Encompass is reporting 1.2 billion. Exactly 1,267,900. See that as EBITDA?
I do.
Okay, so that's the earnings. So then if you could turn to the worksheet that Encompass attached to the CON, the agency's worksheet. If council wants to get that in front of you, you can.
Can I have the base number, please?
I don't believe it has a base number. My copy.
that's the financial worksheet.
Yeah, financial work.
There were a couple different ones. Are you referring to the one?
Read, not the.
So that's attached to the completeness letter, which is Exhibit G.
That, I believe that's the real estate. This, I believe, was submitted with the original.
Oh,
CON.
well, there's the hospital only
Yes.
and the real estate are both
I
submitted.
have no questions with respect to.
I don't know why they were submitted twice, but there is one submitted with Exhibit G. There are actually two submitted with Exhibit G. One was the real estate, the other was the hospital. You're referring to the one that was submitted with the application
For the hospital.
for what the difference is or why that was submitted twice, but there's the potential that it was inaccurate or something, and that's why I don't know.
Yes.
There you got it. So, speak in your planning about, bringing the financial strength of, Encompass Health to a given market. So with respect to the net patient service revenue that you're projecting for the Branford facility, Mr. Gooch, you see the line item 5?
Yes. Line item are between 4 and 5, you mean?
Yeah, net patient service revenue. And then there's Medicare and then Medicaid. Okay. So in year 1, your projections are $17,417,820 worth of revenue, net revenue coming from Medicare. Is that correct?
I see that, yes.
Okay. And in contrast, you have a projection of $880,944 for Medicaid.
See that?
Okay. And so you're projecting basically 17 times more revenue coming from the Medicare program than you are Medicaid. Is that right?
Based on the numbers before me, yes.
Okay. And when you look at year 3, the projection for Medicare jumps roughly $12 million, and you're projecting $29,699,912 of revenue from Medicare, right?
Medicaid, yes.
Medicare, 29,000. Yeah, okay, okay. And in contrast, by year 3, so you got a $12 million jump there, you're projecting $1,430,382 worth of Medicaid net patient revenue. So Medicare goes up 12 million. I'm just asking you to verify, whereas Medicaid goes up roughly $600,000.
Question or statement?
No, it's a question to you that I'm asking you to verify.
That's what the numbers say, yes.
And in the response to OHS issues, at table 1, page 3,
Okay.
so here you have 4 months of operations for Encompass Health's Danbury facility. See, Danbury actual 4 months.
Okay.
You have 0 patient revenue from Medicaid as in terms of percentage, and 94% from Medicare. Is that right?
Yes, I believe that is accurate.
No further questions.
Him or?
No further questions. Mr.
Okay. I have until about 2:30. We're supposed to have wrapped up by now.
All right. Dave, a few questions for you. I believe you mentioned in your direct testimony that the facts for the need for the Branford facility are strong as they were in the Encompass facility.
In terms of the gap in care, yes, that was my statement.
But at the time that the need analysis was done for the Danbury facility, the Medicare fee-for-service percentage that you put in line 2 as you go through your methodology in Connecticut, that was 56%. You recall that?
I do not recall that. You'd have to
I've
tell me that.
got a copy of your.
If you just tell me what you're referring to, I can pull it up.
Marty.
Jason? We get that, and I'll wait for the hearing officer. It's great.
Are you referring to her testimony from the prior docket?
Oh, okay. I didn't realize that. I have that too. Give me a second.
That's in October 21.
And what exhibit was that?
I don't have. I pulled this off the portal. Sure, so there were no Bates numbers, so I apologize, but I'm going to 1, 2, 3, 4, 5. On the 9th page of her pre-filed testimony from the. And if you could go there too, Ms. Chapin.
It starts lines 1 through 3 at the top.
Yeah. See that? Okay. So the time of Branford in line 2 statewide percentage of Medicare fee-for-service beneficiaries, that was 56.8% at the time, right? That's the data you used in your need methodology, rather.
That's correct. That's what it says.
And now when we turn to Bates page 635 of your testimony, in this proceeding,
There.
line 2, the statewide percentage of Medicare fee-for-service beneficiaries is 40.3%. That was used in your calculation this time.
That's correct.
Okay. So that's in 5 years, that's a 16% drop in the fee-for-service traditional beneficiaries that your client Encompass Health of Branford is saying is the key of their they're trying to serve. And in fact, you're saying in your need methodology that national data of fee-for-service traditional Medicare is what this agency should rely on, because Encompass in 2021 got approved to run the Danbury facility. You're saying it's still a good model, even though there's been that 16 that drop, right?
It's 16 percentage point change, to be very clear for the record. And yes, I am saying it's still relevant, because if you go back to my slide 2 and you look at the other states that have had similar change in Medicare fee for service and thus similar change in Medicare Advantage, they still have significantly higher IRF utilization than Connecticut.
Right. Isn't it also true, sort of compare apples to apples, that at the time that your submission in 2021 was provided, there was no other inpatient rehabilitation facility in Connecticut, including the Danbury facility that's now been only open 7 months. That's right, correct?
Ask me that again. I'm not sure I followed you. I'm sorry.
In your look at the national data as the need analysis here, but when you looked at the market in Connecticut for that first Danbury facility, there was no other freestanding inpatient rehabilitation facility in Connecticut, right?
That's not correct.
Mount Sinai? Okay. With the exception.
And there was no rehab facility, rehab beds in the service area, the Danbury analysis, like there are no patient rehab facility beds in the service area here. So that is apples to apples.
Mr. Gooch remarked this morning that there's been a recent discussion with Yale New Haven Health about possibly serving their patients in your Danbury facility. So apparently there's the ability to cross over to the Danbury facility, which is now open, running about 50% capacity, right?
I don't know the percent in front of me. I know it's well utilized, and I know that they're going to accept patients that need that care. It does not mean there's not care that is needed in the proposed service area here.
And so at the time that you also did the need analysis for Danbury, there wasn't an approved 34-bed capable of expanding to 43 beds inpatient rehabilitation facility of PAM Health in Waterbury, correct?
That's correct. It's 34 beds that can increase to 42. However, as I stated previously on page 14, my presentation, I have accounted for those beds, and there is still a need for 59 beds.
Yeah, hearing officer, with respect to those 2 slides that were submitted to OHS yesterday, we are respectfully asking that we have time to submit a link file, because we need time to obviously analyze the data that Ms. Chafin's presenting. But I hear you. But up to this point, up to that filing and your corrections of both the own agency's estimate of bed need that you say are corrections and Gaylord's, you didn't make a mention at all of the existence of the Waterbury PAM Health facility that's scheduled to open in 2027. Nowhere in your CON application, nowhere in your need analysis. Is that right?
Correct. No, that is not correct.
Where'd you put that? You're relying on national data. I'm interested on where you state specific.
If you turn to Bates stamp page 52 and Bates stamp page 55, what I show and consider is the PAM, IRF, and Waterbury, and in both instances, I note that it indicates the IRF was approved but is not yet operational. It is outside the service area.
In terms of your calculation of need, even though that was right in, I'm asking more. You didn't account for that IRF facility. You said that it's outside the service area, so it's a different service area.
It is correct in terms of the population that will primarily be served by this proposed hospital. That's correct.
Right now, if you could turn back to the same exhibit, table 1 in the completeness questions, Bates number 493. Your list of, Encompass Health's list, referring hospital. So, were you aware that Waterbury Hospital and St. Mary's Hospital, which collectively make up 13% of the projected volume, that Health in its certificate of need, which is administratively noticed, projected 90% of its volume coming from those two hospitals?
I did not look at that specifically, but if their projected patient population is 90% of those hospitals, and this Branford Hospital is another, I guess it would be 13%, that does not mean that there are not even more patients out there to be served. And it does not mean that it's the same patient population that both hospitals are proposing to serve, because there are significant patients in need for services. So the overlap here does not necessarily mean it's one or the other, that either Branford will get the patients or that
They'll be.
Pam will get it, because that would assume there's not enough patients for both. Does that make sense?
Yeah.
Might not agree with
That's to me.
Say what I'm saying.
Well, what I'm saying is it's going to come from the same source, and you're both counting on a significant percentage from there, besides the two hospitals that are participating in the mandatory team project. That's my only point. And we're also aware that
We're bumping up on an hour now. I'm mindful of the fact that
promise I
has her time.
be 5 minutes.
Okay.
Okay. And I'm okay with it. All right. So I want to just, go back to your feeling and repeat it throughout that the need methodology using national fee-for-service data is an appropriate need methodology for this agency to consider. Right?
I believe that is an accurate estimation of the bed need. And I also want to point out that when you consider the MA population specifically and separate it, slide 15 of my presentation, there is still a minimum of 40 bed need.
And in your need analysis, you have no state-specific data that shows poor outcomes in the skilled nursing facilities that you're saying the Branford facilities more appropriate for and at lower cost. You have no poor outcome data from home health agencies in Connecticut about those rehab patients at significantly lower costs than your facility, or any of the hospitals that you're referring that have inpatient rehabilitation units that they're having poor outcomes. I'm talking Connecticut-specific data, Ms. Chafin. Do you have any of that in your need analysis?
No, I did not base this on the patient examples that we were to gather that the records talks about the physicians that have testified today.
So I just want to recap where we've been. So you think it's the right methodology?
Stand by the methodology.
Okay, and it's the right methodology, even though the percentage of Medicare fee-for-service patients in this state has gone down 16 points since Danbury. You still think it's the appropriate benchmark to use it for this agency?
Do, particularly when you consider
Let's see.
how the IRF charge rate here compares to other states that have similar or higher care advantage penetration rate.
And you also think it's the right methodology for this agency to rely on, even though now the Danbury facility's been open for 7 months and there's still another inpatient rehabilitation facility to come online in late 2026, early 2027. Still the right methodology using this national data.
That is correct, because neither of those IRFs are located in approximate to the vast majority of the patients expected to be served.
And you think it's still the right methodology, even though Medicare now has the team bundled payment program that 2 of the 3 leading referral sources are mandatory participants. Still the right methodology to use.
Because of all the testimony from Mr. Gooch.
And you think it's the right methodology, even though MedPAC is attached to the March 2025 MedPAC report at page 249, even though the Medicare Payment Advisory Council has said there are enough IRFs and also suggested a rate cut with respect to IRFs. You still think it's the right methodology?
That's because I would not rely on a national statement that access is sufficient when it's not an IRF and or this proposed service area.
No more questions.
Thank you. Let's take a 5-minute break. Okay, we'll come back and redirect. So we'll come back at 43. Okay, you can stop recording.